Hello, everybody. It's Chief Rumentrout, and I wanted to cover the Forms, Billing, and Signatures tab of ESO. And we're going to cover these together because these three tabs take up a very little portion of our charting time, and they're very easy to do. Right, so we'll start with the Forms tab. The Forms tab is the location for any specialty information regarding a patient's clinical condition, right? So if I go on somebody and I am told, hey, this person has slurred speech, a headache, maybe some unilateral weakness, this Forms tab allows me to document specific assessments related to a stroke because that's what we're assuming is going on, right? So we can come in here to our Cincinnati stroke scale, document when we performed it, when the symptoms started, when their last known well time was, right? So maybe they said, hey, I woke up this morning, I wasn't feeling that great, feeling a little off, but the unilateral weakness didn't start until 12:30. Man, now my last known well time would be this morning. The onset time of symptoms would be at 12:30. Then I can come down here and perform the exam. If I'm not sure how to perform the exam, I can also scroll down just a little bit further and look at the screening criteria for that specific exam, right? This allows us to provide a consistent exam to all of our patients that are presenting with these symptoms, right? And this consistency also allows us to be able to effectively communicate our findings to the hospital, right? So that what we see and how we communicate it is what the hospital expects to hear. And it's going to be interpreted in the same way that they would interpret it or they would communicate it. We also have the same for the BFAST stroke scale. We have a burns form that you can use to figure out your body surface area of burns. A CPR form if we have somebody that was in cardiac arrest or currently is in cardiac arrest. And notice that the form expands in size as you answer questions. We have a motor vehicle collision form. So this talks more about the mechanism of injury, the damage to the vehicle, and where we found the damage on the vehicle. Outbreak screening. So if somebody has COVID, you can select the COVID-19 outbreak and answer the questions. It's something we used to use real frequently, not so much anymore, but it's a good thing to remember if you do come across somebody that has COVID-like symptoms. Advanced airway. Anytime you have a patient with chest pain, these, again, questions that we should be asking. This acts as a good reminder and also allows us to document them uniformly so that we can look at all these charts and be able to see and identify any trends. The billing tab is where the patients were traditionally how the patient was going to pay goes. Now, all of our hospitals except Willamette Valley Medical Center have the healthcare data exchange. And what this means is that when you show up at the hospital, you scan in the patient's wristband in that data field in the incident tab that I showed you earlier. And because of that scan, they're able to see all the information from our documentation, and we're able to see all of their documentation. And that includes the patient's insurance information. So that stuff automatically imports. If you do go to a hospital that is Willamette Valley Medical Center or a hospital in Portland, because maybe we're doing a transfer out of West Valley Hospital, you would get a face sheet and make sure you put that face sheet in the drop box in the paramedic room. The final tab is the Signatures tab, all right? And we're going to spend just a little bit more time on the Signatures tab because I want to make sure we all understand what's going on here. So the three types of signatures we're going to use are these billing authorization, the provider signature, and the refusal signature. So anytime we treat a patient, right? So we transport them, or maybe we provide them with care that's going to end up getting billed, we should be getting a billing authorization signature, right? And so we always prefer signature one. Signature one is always the best, and that signature is directly from the patient or directly from the patient's parent if they're a minor, and only if they're a minor, right? And that signature allows us to bill that patient. It allows us to share the information and makes it a lot easier for us to process the things we need to process, so that we can get some reimbursement for the services we provide. If we don't get these signatures, we end up going after them later, which causes additional frustration to the patient and also increases the length of time it takes for us to get reimbursed. So it's really important we do it right the first time. Did you provide them a notice of privacy practices? Yes or no? Ideally, that should always be yes. And then do they agree to the billing authorization, and do they acknowledge, that they got the HIPAA information, right? And we provide that billing authorization information both in English and in Spanish. So please make sure that you present it into the language that they prefer if it's one of those two languages. And there is a room for a witness signature if the patient's signature is not legible, or if they just put their mark or their X or what have you because they weren't feeling well. Signature 2 is for those situations where you can't get a signature from the patient, but either somebody who has the authority to approve care for the patient, right? So a family member, next to kin, medical power of attorney is great, or somebody from the sending facility, right? So you go to a nursing home and you're taking away one of their patients because maybe they're altered or unresponsive. If you can get that Section 2 signature, that allows us to go through the process of submitting all the claims without involving the patient or delaying that process. And finally, if you can't get any other signature, you can go for signature 3. Now, signature 3 is less than ideal. Signature 3 means that we have to bother the patient after the fact, try to find that insurance information, and get a signature from them before we're able to submit a claim on their behalf. So again, not ideal. Really prefer signature 1 or signature 2. Signature 3 is a last resort. And again, this billing authorization is only when we perform only when we do something for the patient that we're going to bill, right? So we start an IV and give dextrose, or maybe we transport the patient. Every time a chart is written, there should be a provider signature, and the provider is responsible for verifying the content of the chart and assuring the quality of the documentation, right? Ultimately, even if someone else entered information for you in the chart, so say we had a cardiac arrest and I'm doing some data entry for one of our paramedics, if they transport that patient and finish the chart, they're ultimately responsible for what I put in there, and they have the ability to change it or alter it if they think it's inaccurate or it's not painting the correct picture. And then provide the signature here. Refusal is the final signature. Refusal includes a few additional data fields to make sure that we are properly assessing our patient's ability to refuse, right? So do they have the capacity to refuse care? Now remember, competency is a legal definition, and that is determined by a judge, which none of us are. Capacity is something that changes based off of the patient's condition and any other external factors, right? So if somebody imbibes and drinks enough alcohol that they're slurring their speech, they don't have a good recollection of what's going on, they don't appear to be able to weigh the risks and benefits of refusal, they do not have the capacity to make that decision. And then that is something we as paramedics and EMTs can assess, right? And so this helps to give us tools so that we can clearly document the patient's ability to make those decisions. So yeah, they're 18 years of age or older, but they had the etiologic drug use. That person I described was disoriented. They're unable to understand the information. Okay, medically, maybe they have that slurred speech and an unsteady gait. They do not have the capacity to refuse. We can leave it in there. Inversely, maybe they do. They clear the capacity assessment, and that allows us to move down. Did we make any notifications to the patient or the person responsible for the decision making? And that's just saying, what did we tell them could go wrong, right? Because there is no choice that we provide, even transport to the hospital, that is a zero harm choice, right? Because even a transport to the hospital, there could be, a collision, there could be medical error, right? So really, it is again a risk benefit for whatever choice they're making, right? So maybe we say, look, we recommend you get further evaluation and treatment. And if you don't, it's going to cause harm. You really shouldn't go POV, because if you go POV and you have that seizure, you're not going to be able to protect, the driver's not going to be able to protect their airway, or you're going to crash the car. And I'd rather, take you to the closest facility and not Salem. But if you really insist on Salem, we'll let it go this time. Or, man, dude, you're doing just fine. Someone else called for you. You look fine. You say you're fine. I don't think there's any medical need. No transport's really needed. Click it. Let them know. And maybe you say, hey, why don't you follow up with your primary care doc? So we say, advise patient to follow up with primary care physician, right? And I'm the one who got that refusal. I get the signature saying that's what I did. I did the capacity assessment, all this stuff up here. And then I get the patient refusal and they say, well, I don't really want transport, or I really don't want to go where you told me to go. Any comments that are relevant to that, and then allow them to read through this. The big thing is when they read through this, they're also saying they got that notice of privacy practices. And then you got your patient signature. Click there to sign. If the patient's refusing to sign, they're unwilling to sign, try to get a witness. If it's one of those refusals where the patient should really go, you're trying to convince them, they're insistent on no, you feel a little uneasy about it, get the patient's signature for the refusal and then get a witness. There's nothing wrong with getting that witness signature if you think that there's a potential that that refusal is going to be questioned, because we want that information. We want that person to attest that you did the best job you could in those situations where that patient really should have gone to the hospital. And that is the forms, billing, and signature tab.